Hi, I am Dr. Kyle Allen, Medical Director for Geriatric Medicine and Lifelong Health, Vice President for Clinical Integration, Riverside Health System. Caring for older adults and those with serious and complex illness requires that we change how we deliver that care. Team-based care has been shown to be one of the most effective solutions. There are many different types of teams, as we all know. Different roles, different sports. There's the individualized sport, such as golf or tennis, versus a true team or interdisciplinary model, such as soccer. Providers, however, are trained in the individual or autonomous model. However, that role is changing. Interdisciplinary team care is one of the most effective tools for improving the care for those with serious and advanced illness. When working effectively, these teams can produce exponential results. However, what we have to move towards is these teams models, which will give us great benefits. The teams create a shared adult learning environment. And from that adult learning environment, we have a halo effect that can impact other units, hospital units and facilities. That results in the changes of the culture of care. There is an empowerment of the staff to practice at the limits of their license or training with improved competence, improved patient satisfaction, quality, and outcomes. As you can see from the diagram, working in interdisciplinary teams where we're centering the team around the patient, family, and providers can lead to improved safety, quality, and outcomes. Now you will hear from several Riverside Medical Group physician leaders how this team model is changing care for older adults and those with serious and advanced illness within Riverside Health System.
In his 2011 address to the graduating class of the Harvard Medical School, Dr. Atul Gawande discussed the revolution that was going to be occurring in healthcare. 21st century healthcare is being delivered using 19th century systems. The core structure of medicine, how it's organized and practiced, emerged in an era when the doctor could hold in his head all the needed information to care for his patients. All he needed was an ethic of hard work, prescription pad, a secretary, and occasionally to borrow a hospital to provide a nurse and a bed for his patients. This system valued autonomy, independence, and self-sufficiency, what Dr. Gawande called the, quote, cowboy doctor, end quote. Medical complexity, unfortunately, has far exceeded our individual capabilities as physicians. So what Dr. Gawande suggested to replace these cowboy doctors, what he suggested to these Harvard graduates, that these should be replaced by pit crews. He described how physicians will be part of a team combining individual talents and skills to work in a coordinated fashion. He went on to describe his work for the World Health Organization around restructuring operating rooms to work as teams, as pit crews. He was able to demonstrate when teamwork and teamwork culture was embraced by the OR team, surgical mortality was cut by almost 50%. So how does Riverside fit in with this teamwork revolution? Well, first, we have a better analogy than the pit crews, thanks to Dr. Kyle Allen. Riverside is building soccer teams. Like pit crews, they work as a team, have a shared goal, work in a highly developed system of communication, but unlike pit crews, they're more fluid, less siloed, and more able to respond to the changes that occur during the game. So where are these Riverside soccer teams? Well, a few examples. Dr. Peter Anderson has developed Team Care, a soccer team concept for office-based practice. In Lifelong Health, we have our PACE programs. At their heart and central to their mission, they deliver care through an interdisciplinary team, working as highly effective soccer teams to manage the health care of the frailest elderly. Well, that's for patients. What about the system? At the system level, how do we manage the populations of patients we care for? Well, let's look at our roster of players. Besides the hospital and the hospitals, we have our Riverside Medical Group, we have home care, hospice, skilled nursing facilities, long-term care, rehab facilities, and continuous care communities. These teams need highly developed communication systems. Riverside, with the leadership of such folks as Charlie Frazier, has been consistently named as among the nation's most wired health system. And healthcare should be driven by data, and Riverside is developing a sophisticated data analysis system that will create dashboards that allow the providers to focus their healthcare efforts. What about the culture of teamwork, and perhaps the most difficult transition that we need to make? Look at the work of Dr. Barry Gross and Terrace Kennedy on Team Up for Safety, a system-wide celebration and cultural education process for teamwork. We are ahead of the curve, yes we are, and we are well positioned for the future. Do we have the vision, the will, the drive to continue to be a national leader? And hearkening back to my cowboy days in Montana, I'm going to answer that with a you betcha.
What is a patient-centered medical home? There's not really an official definition, but the definition used by the National Committee for Quality Assurance is the one shown on the slide. To become a medical home, you have to satisfy 6 basic standards. We're already doing most of this. The first standard is enhancing access and continuity. We have to provide access during and after office hours, and also by phone and by two-way electronic messaging. We provide continuity of care by utilizing our personal health team and having the patients involved. We use data we've collected on these patients to be able to identify and manage patient populations. We need to know which patients most need our care. We use chronic disease management plans to take care of these patients. Also, we need to be able to plan and manage the care of individual patients. We use evidence-based medicine, care pathways, and chronic disease self-management plans. We provide self-care support and community resources. Engaging patients in their own care helps to provide better outcomes. Patients need to be educated as to our plan, the goals, and any red flags that may crop up to let us know. We also need to be able to utilize community resources when needed. We track and coordinate the care of the patients beginning from the time they leave our office to have their referrals, labs, and imaging done, and any transitions of care from acute care to post-acute care. We also measure and improve our performance. We need to know what our quality numbers are and how efficient we are, and also how well satisfied our patients are using Press Ganey. So how does a patient-centered medical home help lower our costs and improve outcomes? Getting patients into our offices and into the system helps shift care from emergency departments and reduces admissions. Outpatient medicine is much less costly than inpatient medicine. We need to keep them within Riverside Medical Group. That is critical to control costs. We have no control if they're not in the system. We use the data we have collected to identify groups with multiple comorbidities and focus on chronic disease management. Using evidence-based medicine, care pathways to better manage diseases and reduce visits, admissions, and readmissions. Engaging and educating the patients is critical. It helps to promote self-monitoring and self-management and allows for earlier intervention. Tracking and coordinate care to be sure our plan is fulfilled, tracking all labs, imaging, diagnostic tests, and referrals to be sure they are completed and we have the results. We also need to coordinate acute care, post-acute care, and home transitions to improve care and reduce admissions and readmissions. We also measure our performance as well as our patient experience to see how well we are doing and how well the patients are satisfied. As you can see from the slide, the majority of our resources are expended on a very small group of patients. Patient-centered medical home does very well with the majority of our patients, but where do we need help? We need help with the 2 to 5% of the sickest patients and the frail elderly. How can we help with the frail elderly? Number one, we provide access to the system. We can't manage these patients if they're not in the system. We identify those in the system to see which ones need our help the most. We coordinate their care with CareMore and the extensivists, and we utilize programs to achieve successful outcomes. Examples of these programs that are being developed or are developed at Riverside are geriatric assessments, geriatric advanced care, house calls, the ACE units in the acute care facilities, and palliative care and hospice programs. It's very difficult, if not impossible, to provide this level of care in the primary care office, even if we had the specialized training and staff and space.
Good morning. I'm Charlie Frazier. I'm the Senior VP and Chief Medical Information and Innovation Officer. I'm going to talk to you this morning about the Dementia Care Initiative, and that's an ongoing project at the Geriatric Medicine and Care Initiative's Performance Improvement Work Group. That's quite a mouthful, isn't it? I think we might need to find another name for that, just so the members can remember what we're called. Now, you might wonder why dementia. And in fact, we did discuss other clinical entities involving seniors where we have an opportunity for improvement. But in the end, we chose dementia because it is and has such a significant impact clinically, socially, and economically. In fact, the Alzheimer's Association just released the statistics on dementia for 2013. 5 million Americans aged 65 and older have dementia, a prevalence of 1 in 9. Think of that, 1 in 9 folks over the age of 65. And of course, it impacts the end of many Americans' lives, with 1 in 3 seniors having Alzheimer's disease or another dementia when they die. And while something else may have caused their deaths, Alzheimer's disease specifically is the 6th leading cause of death in the United States. Now, I think all of us can appreciate the tremendous cost burden dementia places on our healthcare system. But what is less obvious is the economic impact of the care given by family members. In 2012, 15.4 million caregivers provided an estimated 17.5 billion hours of unpaid care, valued at more than $216 billion. Now, I wonder a little bit about the validity of those numbers, but suffice it to say that dementia accounts for a significant outlay in paid and unpaid care for those who suffer with these diseases. So our Geriatric Medicine Improvement Work Group has been working on a model of care for dementia. It's just one of many evidence-based care paths that we have been working on and implementing across Riverside Health System. We've done one for COPD, we've done one for hypertension, we've done one for heart failure, we're working on one for Coumadin and warfarin. And for each of these conditions, we have reviewed the current evidence, developed care paths, and have embedded those care paths into the electronic health record. Included in this process is the development of metrics, dashboards, patient education, patient self-management tools, patient registries, etc. In the case of dementia, we have planned a pilot project for something called ClearPath, which is a care management process to support dementia patients and their families and caregivers. Once we finalize the dementia care model, we hope to implement CarePath as a pilot at the 3 practices with the highest dementia burden in RMG. We also review something called Advanced Brain Care, which is a dementia care model built upon a long-established electronic health record at the University of Indiana. What they are really interested in is selling their consulting services to implement a model, but it was the consensus of the group that we have progressed to a point that really didn't hold a lot of value for us at this time. After reviewing the current literature, we started putting the model together. We elected to leverage the Medicare annual wellness visits that we are doing, which includes cognitive screening as part of that. We currently endorse 2 screening tools, but decided going forward to recommend only one, something called the MiniCog. We did so because that tool includes a step that the evidence would suggest is a good predictor of sufficient cognitive skills to drive, which could be useful later in the assessment if needed. Now, if the cognitive screen is positive, then a formal evaluation should ensue. That evaluation should include a more formal cognitive assessment, certain laboratory tests, a medication review, assessment of general functional status, screening for depression, and potential brain imaging. While we endorse the Montreal Cognitive Assessment, affectionately called the MoCA, for the cognitive evaluation, we are still deciding on the most appropriate of the other screens and assessments. Based on the findings of that more in-depth evaluation, the patient may require referral to one or more specialists, and we are likewise still refining and documenting the clinical parameters that would indicate referral to specific specialties or disciplines. So in summary, we are developing this dementia care path based on the current evidence and embedded into the electronic health record that guides our physicians and our care teams to provide the best care to our dementia patients and their families and other caregivers. It's an effort to define, while based on the evidence, the Riverside way of managing dementia in order to facilitate and streamline that care, not only for the providers, but also, and most importantly, for the patients. Thank you.
I'm Dr. Greg Shivers, physician at Riverside Walter Reed Hospital and Service Line Chief in the Middle Peninsula, and would like to discuss the Riverside Health System Delirium Prevention Project. Perhaps you yourself have experienced moments of delirium while taking a bite of a delirium bar, listening to trance music from the Canadian band Delirium, or admiring the fine movements of a Concord Delirium march. Popular culture tends to think of delirium as an emotion or state of uncontrolled excitement, typically in a pleasurable sense of the word. But in the medical context, delirium is quite different from these more commonly held concepts. Delirium, described by surgeon William Bickers as a descent into the maelstrom, is a terrifying experience for both patients and families. Let me describe a typical patient suffering from delirium. Patients often have difficulty participating in their care. They're often agitated, but sometimes subdued, tend not to want to eat, and often want to get out of bed, putting themselves at increased risk of falls. Delirium is recognized as a measure of hospital quality by several accreditation organizations, such as the Agency on Healthcare Research and Quality. And although delirium affects up to 40% of hospitalized patients, it is under-recognized, often not understood by families. There's been a lack of evidence-based care, and there are a lack of tools for effective delirium management. Delirium has a cost, obviously to the individual patient, but also to families, communities, and health systems. The mortality is equal to having a heart attack or a severe infection, and the length of stay is often increased by up to nearly 4 days. The cost per case is estimated to be $2,200. We have an opportunity to improve the care of patients with delirium. Yale University has demonstrated through their HELP program that incidence of delirium and outcomes can be improved. At Riverside Health System, starting with a pilot program at Riverside Walter Reed, we hope to improve the care of patients with delirium by initiating a delirium prevention project. We started with a survey in July in 2012, and we found that 11% of patients aged 55 and over were either admitted with or developed delirium while hospitalized. We plan on implementing project components such as nursing assessments and screening tools, order sets to guide care plans and appropriate medication usage, education for staff, families, and patients. We hope to integrate delirium care into our interdisciplinary plan of care rounds. Of course, our goal is to reduce the occurrence of delirium in hospitalized patients by improving early recognition of delirium and providing an evidence-based approach for treatment of delirium if it occurs. Thank you for your attention and your time.
Good afternoon. It is a pleasure for me to introduce the work of our team in developing a disease management program for congestive heart failure. The goals of this team is to develop and implement systems and formal practice guidelines to optimally treat the hospitalized patient for acute decompensated heart failure. We want to extend these guidelines to the outpatient setting, coordinate and communicate care among all healthcare providers across the system. We want to provide comprehensive patient and family education focused on self-care. The goal of this is to reduce the planned unhospitalization of patients who are admitted with congestive heart failure for both cardiac and non-cardiac causes. Our ultimate goal is to reduce 30-day readmission. As a form of an example, Riverside had 291 index admissions, Medicare only, in 2012. We had 49 readmissions. The average age of these readmissions was 80 years old. The number of days between admission and readmission was 14 days. 39% of readmissions had a heart failure diagnosis. 16% had cardiac-related diagnoses, but not heart failure. 16% had respiratory problems, 13% had kidney problems, and 16% had no cardiac or other diagnosis available. Now, of these patients that were discharged, we followed where they went. 49% went home, and they had no additional services. They accounted for 39% of our readmissions. 19% had home health, and they accounted for 14% of our readmissions. 20% were transferred to skilled nursing facilities, yet they accounted for 35% of our readmissions. We know that this is a problem. This is an issue where patients transfer to these other locations where we did not expect for them to be readmitted. They came back. So we closely looked at these patients and tried to find out why they were readmitted and address them. Self-care, teaching the patients and their families and identifying emotional, social, financial needs are things that we at Riverside can and will do. Reducing the readmission rate is the focus, but the disease management program is ultimately what's going to determine whether we improve care to our patients. The continuum of care is not just a statement. It is something that we live. It is something that we want to do, and it's something that I think we do well. The attempt to take a patient with one diagnosis and carry them through so that we will not see them back at 30 days is certainly one goal. It's an outcome that we measure. But making certain that that patient can take care of themselves both now and in the future is something that we will strive for.
In the 25 years that I've been with Riverside, I've seen Riverside deliver rehabilitation services to many patients for many reasons in many settings. For example, every year, 350,000 people elect to have hip replacements. 500,000 people elect to have knee replacements. 450,000 people unexpectedly have hip fractures or pelvic fractures, and only a small percentage of those return back to the activity levels they enjoyed before their fall. 800,000 people have a stroke every year. That's every 40 seconds somebody has a stroke. 1/3 of those are left with long-term disability. There are several different settings in which a patient could receive physical rehabilitation. After a doctor's visit, the doctor may recommend an independent home-based program, giving the patient some instructions on how they could do their own routine to improve their balance, to improve their abilities to stay at home. The physician may order home health therapy to go into the home, to provide training, exercises, and maybe some adjustments to the home setting to allow someone to stay at home who might otherwise not be able to. On the other hand, an individual might be eligible for an outpatient-based program. They might go to one of Riverside's wellness centers and participate in an independent or guided program within that facility. They may also require more skilled services, and a physician may order physical therapy, occupational therapy, speech therapy, respiratory therapy, any one of a number of therapies to help try and keep the person more independent and more able to stay at home and more able to perform the activities they need to and want to perform. Unfortunately, there are those that have more serious needs, and their needs may need to be met in an inpatient setting. For example, the Riverside Rehabilitation Institute is the only licensed acute care rehabilitation facility in the area. Patients may go there who have more significant rehabilitation and medical needs. As anyone who's been working in healthcare knows, over the years we've seen a ratcheting down of reimbursement for different services. Services that were once done on an inpatient basis are now done on an outpatient basis. Rehabilitation is no exception to that. At the Riverside Rehabilitation Institute, 10 years ago, patients with hip fractures and knee fractures came there routinely. Now, most payers will not cover that, hence the development of the Riverside Rehabilitation Centers on the campus of the convalescent centers, where most insurers still do cover that. But who knows, perhaps in the future, it'll be expected that patients will go straight home from the hospital after knee replacement and either do outpatient therapy or home therapy. Fortunately, Riverside has all the components to deal with whatever comes our way in terms of where rehabilitation will need to be delivered. What is also fortunate is Riverside has the tools to track the outcomes of rehabilitation in these different settings. Whether it be home therapy, outpatient therapy, or inpatient therapy, Riverside has software tools and programs in place to be able to demonstrate the progress made by these patients who are coming in for inpatient rehabilitation. We can provide that information to the physicians who have referred them to us. We can, of course, let the patients see the progress that they've made. And equally importantly, we can show the payers that they're getting their money's worth, that Riverside is giving them the rehabilitation they expect their patients to receive. So whatever the future has in store for Riverside, Riverside has the tools to deal with it, and I'm glad to be a part of that.
Greetings. I'm James Dudley, and I'd like to take a few minutes to discuss our continuity of care team at Tappahannock. What we are is a group of providers. We've got hospital-based folks. We've got folks from the long-term care facility at the Orchard. We've got emergency department folks, nurses and staff from the intensive care unit and the medical surge units. And we bring them all together to discuss the plan of care and the design of handoffs. Why do we do this? Handoffs are dangerous. When a patient leaves the hospital on one set of medications and with one plan and goes to the next setting, if that handoff is not done perfectly, the patient can suffer. So where do we do this? We do this in our committee structure initially, but then once the design is in place, we do it in real time with the patients and their families when they're in the hospital. Is this plan effective? We've implemented it recently and found that by having particularly the telemedicine link between our inpatient service and the skilled nursing facility, that we can add value by decreasing readmissions. And as most of us have learned recently, the government and other payers are not going to reimburse us when patients are readmitted within 30 days of a hospitalization. And so we've got to do everything we can to decrease readmissions. It improves quality and safety through the ability for staff to ask questions and provide answers to one another. And that effective communication absolutely ensures safe and effective handoffs. So what have we learned thus far? We've learned not only is it good for patients, it's really good for patients' families. When they leave our facility and arrive at the front door of the skilled facility, they're greeted by people whom they have seen on the telemedicine equipment. And then likewise, the receiving staff greets them because they recognize them. And so it really helps to allay everyone's fears. Some of the challenges are that it requires a high level of coordination and logistics. And that can be a challenge, both to get the equipment to always work smoothly, but also to have the equipment work in the face of foul weather and busy schedules, both in the hospital and in the receiving facility. So what are our next steps? We're trying to integrate more broadly a chronic care management model where we really take the plan of care deeply into the management of congestive heart failure, chronic obstructive pulmonary disease, complex diabetes with comorbid conditions. And we use not only the hospitalists as the leaders of those teams, but also the hospitalists in the next phase, which are termed transitionists. These are doctors who will help them transition to the next level of care. So with that, that's basically a summary of where we've been thus far, and we very much look forward to the next steps.
As you can see from the physician leadership, these are several examples. We are turning the flywheel to transform and re-engineer Riverside to meet the needs of an aging population. There is a cast of thousands, many shoulders pushing, heavy lifting, but we are successfully building the teams and changing the playing field that will create the Riverside care difference.